So welcome to this MPA MIA webinar this evening, the community webinar series. Tonight's webinar will be focusing on the role of the gut microbiome in immunotherapy treatment for melanoma. My name is Emma Gaynor and I'm the National Support Manager at Melanoma Patients Australia. Melanoma Patients, MPA, is an independent, not-for-profit charitable organisation dedicated to providing vital representation and supportive care services to ensure no Australian affected by melanoma walks alone. This webinar is also proudly run in collaboration with Melanoma Institute Australia. MIA is a not-for-profit organisation dedicated to preventing and curing melanoma through innovative, world-class research, treatment and education programs. Before we commence our proceedings this evening, I would like to take this opportunity to acknowledge country. We would like to pay our respect to the traditional custodians of the land in which we're all on today and their elders, both past, present, and acknowledge the deep continuing connection of Aboriginal and Torres Strait Islander peoples to the land, waters and sky. So tonight's webinar is a part of a three-part webinar series brought to you by Melanoma Patients in partnership with MIA. Our first webinar was on sun protection after melanoma, and the recording is now available on both of our websites. Tonight's webinar will be on understanding the role of the gut microbiome in immunotherapy treatment for melanoma, and our final webinar will be on melanoma in situ. You are most welcome to join us for the last webinar next Tuesday. However, you will need to register online for each one of these if you wish to attend. It's my pleasure now to introduce our speakers for this evening. Associate Professor Ines Silva, Dr. Rebecca Simpson and David Thiele. I would like to also acknowledge at this time that our original MPA community member to present this evening, John Roberts, had unfortunately become ill and is unable to present as planned. So we do wish John a speedy recovery, and we do thank David for jumping in at last minute to be able to help us. So I'd like to first welcome Associate Professor Ines Silva, who is a medical oncologist MIA and in Blacktown Hospital, and a research scientist at MIA and the University of Sydney. After completing her medical training in Lisbon and a PhD in New York, Ines arrived in Australia as MIA's 2016 Medical Oncology Fellow. Her main research goal is to study mechanisms of innate and acquired resistance to immunotherapy in order to identify new therapeutic targets. So thank you, Dr. Ines Silva, welcome, and we look forward to hearing your talk this evening.
Thank you so much, Emma. Let me just I'm going to share my screen. So I hope everyone can see my screen. So first of all, thank you so much for the kind invitation. And today, Rebecca and I were going to talk about understanding the role of the gut microbiome in immunotherapy treatment for melanoma. But today, what I'm going to do in the beginning is I'm going to basically set the scene. As a medical oncologist, I'm going to explain a little bit where we use immunotherapy, what immunotherapy is, and then I'm going to give the opportunity for Rebecca to explain more about the gut microbiome in the context of immunotherapy treated melanoma patients. So I'm going to start with a clinical case because it's always easier if we start with in a specific context. So let's say that I have a patient, 76-year-old woman that in March 2015 had a primary melanoma resected from her right calf. And then, so the melanoma was removed, nothing else. But 4 years later, the patient self-detected a lump in the right groin. And that was confirmed with a biopsy to be melanoma. So there was nothing else in terms of prior history, past medical history, like hypertension, diabetes. The patient is a retired nurse, non-smoker, and drinks approximately 2 standard drinks per week. So I don't know how everyone is used to see those images, but on the left we have a CT scan. Okay, so and this is just to explain, this is an enlarged lymph node. And on the right we have a PET scan that basically tells us what is avid. Okay, so and cancer tends to be avid. So, and we can see here, so this is the bladder, but this is abnormal. So this is the lymph node. So what kind of information can we see here? We have an abnormal lymph node that is avid, consistent with the melanoma, and nothing else. So what do we have? We have a woman with a recurrent melanoma. And you probably are aware of this nomenclature about staging, right? Staging means where is the cancer, right? How much the cancer has spread. And this is more for us as medical oncologists. So in this patient, we have a T2B and 1B. But in general terms, this patient has what we call stage 3. But what is important is that, and I'm not a surgeon, but I can tell that this is what we call resectable stage 3. And why is that important? Because that will determine the best management for this patient. But what we know is that even in the cases where there is a resectable stage 3, in fact, surgery sometimes is not enough. So I know that on the right side here, I just put this plot. This is what we call a survival curve, Kaplan-Meier. And I don't want to explain in detail, but what I want you to understand from this, and this is something that medical oncologists really like, basically what we are seeing here is the percentage of patients that are well, alive, or free of disease, okay? So what we really want is this curve to be up there and flat, okay, at 100%. So anything that goes below, so for example, the blue line, the yellow line, and the red line is the worst, means that definitely patients are not doing so well. So meaning that in a resectable stage 3 melanoma, surgery is not enough, okay? So what can we do as medical oncologists to change that, okay? So if the tumor is resectable, why, if the surgeon can go there and remove everything, so meaning, imagine I have a lymph node that is abnormal, if the surgeon can remove everything, why am I still in trouble? Possibly. Because what we know is that even though the surgeon takes everything out that we can see, some cells, some cancer cells, probably have escaped already, okay, and will cause some trouble later on. So what we want now is with systemic therapy, so drugs that we give through a drip, for example, we want to mop up any cells that might have escaped. And there are two main strategies. One we call adjuvant. Okay, you don't need to know all that, but just the concept. What is that? Is to give drug therapy, okay, so through a drip, for example, after the surgery, okay, which is represented here. So the surgeon takes everything that he can see, and then we give drug therapy. And for this talk, I'm going to talk about immunotherapy only, because that's what led to the work that Rebecca is going to share a little bit. So we give immunotherapy, and immunotherapy, as probably some of you know, does not target the tumor directly. It's going to boost the immune system of each of us to fight the cancer, okay? So in this strategy, what we do is the surgeon takes the tumor out, and we medical oncologists give immunotherapy to stimulate the immune system of the patient to fight the cancer. And we hope that works, right? So how well does it work? So the risk, and this is general, okay, percentages, because this is all patients with stage 3, and we know there is a big difference between the stage 3. But I'd say that the risk of recurrence of the cancer coming back after surgery in stage 3 with no other treatment, let's say about 70%. With immunotherapy, and those are just two names of immunotherapies that are available in Australia, we are able to reduce the risk of recurrence by half, which is very significant. So that's one of the strategies. The other strategy is what we call neoadjuvant. So one is adjuvant, the other is neoadjuvant. What is the difference? Well, very simple. The only difference is that we change the order. Instead of giving, so doing surgery followed by immunotherapy, so adjuvant. We flip the order and we give a short course of immunotherapy before surgery. And that approach, in fact, has several advantages compared to adjuvant. So neoadjuvant, that's probably the only message I want to leave today is neoadjuvant is better than adjuvant. And there are several reasons why, but I want to highlight three. The first of all, the most important one, we know now after two clinical trials, okay, so clinical trials are very important, that's where we get the information. I'm just going to show one, but we have two clinical trials showing that neoadjuvant is better than adjuvant for patients. And that's the most important, really, advantage of neoadjuvant. For example, in a very simple way, imagine a group of patients with the same stage of melanoma, so resectable stage 3. And then they were randomized, so they were randomly allocated to two different treatment arms. One is the adjuvant, so I already explained. So it's surgery followed by the immunotherapy. And in the other treatment arm is the opposite. So basically, patients, instead of having surgery followed by immunotherapy, they had exactly the same amount or number of cycles of immunotherapy, but 3 of those cycles were given before surgery. That's the only difference. And now that you know how to read the Kaplan-Meier curve, and I explain, the top line is always the best. So neoadjuvant was much better for patients compared to adjuvant, meaning that we have a much higher proportion and percentage of patients, so number of patients, that did not have recurrence of the tumor, so relapse, so the tumor coming back when the treatment was given in the neoadjuvant setting compared to adjuvant. The second advantage is that we are able, with the neoadjuvant approach, to refine prognosis, meaning we can tell the patient, okay, you are going to do very well, or you might, probably the response was not great, we need to find something better for you. So it helps managing. Why is that? Because if we do give immunotherapy after surgery, we know that we are helping some patients. We know we reduce the risk of recurrence. I showed that. We know that, but we don't know who are those patients. We don't know who are those patients that are going to benefit or not. And the truth is, we don't help 100% of the patients. So meaning that there is a proportion of patients that unfortunately will still recur. And we have no idea, nothing to guide us, who is going to be in what group. While with neoadjuvant immunotherapy, where we give a short course, so neoadjuvant, the best, that's what I want everyone to learn today. Neoadjuvant immunotherapy, 6 weeks of treatment, followed by surgery, we know the answer already. Because after 6 weeks, then the surgical specimen is sent to a pathologist. Pathologists are the doctor that looks at the microscope, so looks at the specimen in the microscope. And he or she will be able to tell us what we call the pathological response. And that's, I have added here, but basically that's based on the percentage of viable tumors. So when they look at the entire specimen, they will tell us, okay, in that entire specimen, let's say less than 10% is involved with viable tumor, or there are no more tumor, nothing there still. So meaning that the patient had a complete response. Why is that so important? Because we know from putting together information from clinical trials, we know now that if a patient have some response to that short course of immunotherapy before surgery, okay, so neoadjuvant immunotherapy, we know that those patients with some response, they do very well, and the cancer rarely comes back. So it's already some information that that helps us not only with the discussion with the patient, but also us as clinicians to find solutions and options for patients that might need, those patients that did not have a good response, but also probably to reassure patients that had such a good response and most likely won't have any more trouble with the cancer. And finally, and this is probably my passion, the neoadjuvant strategy, in fact, is a great research platform. And research is very important. So I'm a clinician, but also a researcher. And today I'm in the lab. It's very important to try to always know more, because even though we have several treatments that are very good for melanoma and other cancers, I also treat lung cancer, it's important to understand who are those patients that really benefit versus those that are resistant to the treatments that we have available, and how can we help those patients. So more and more, we need to understand like those patients and those nuances. And this is a great platform. And this is just an example. I don't know if everyone is aware of what a biomarker is, but biomarker basically is some kind of variable or information that we have, can be from the tumor itself, can be from a blood, something that is a characteristic that from the patient of the tumor, that helps us defining if the patient is going to respond or not to a treatment, is going to have a side effect or not from the treatment. So those are biomarkers. That's what we call biomarker. And we are still working in that field. For example, this is one type of research that came from this neoadjuvant platform, where, for example, this group of researchers identified two characteristics from the tumor, okay, to be highly associated with a good response. So those are kind of informations we can get from this platform. But going back to our patient, this patient, in fact, had neoadjuvant immunotherapy, which now we know it's much better than adjuvant, 2 cycles of immunotherapy, okay? And after that, the specimen, so the surgeon removed the original melanoma, so the lymph node, sent to the pathologist assessed, and no viable tumor cells. So meaning that the patient had a pathological complete response. And as we know, this is associated with a very good long-term outcome, and this patient is free of recurrence. So in summary, all I want you to learn from my part, okay, is that mainly 2 things. One is that neoadjuvant is definitely the best strategy for resectable stage 3 melanoma. I'm talking about more immunotherapy, not only in terms of patients, of course, outcomes, which is the most important, okay, but also it will help us to move the field forward because of the translational research that can be done in this setting, because we have tumor samples from before and after treatment, we have blood, so we can study those biomarkers, for example. And we also have stools that we can collect. That's why Rebecca could do her amazing work in this field. Only this type of setting really allows us to do this amazing research, and Rebecca's is one of the examples, and we can associate our research with the clinical outcome. So that's one of the key messages, and in our lab we are utilizing that platform to really help the field, to really help patients. And those are the main questions we're trying to identify and trying to address. Because the second key message, so beside that neoadjuvant is the best, even though neoadjuvant is great and we are really, really doing much better, we are not right now helping every patient, right? So the drugs we have available right now, unfortunately, there is still a subset of patients that might be resistant. Not the patient, but the tumor might be resistant. So that's why research work that, for example, Rebecca is going to show and others are key to progress and help progress with the field, but also help patients. So thank you so much for your time. And I'm going to give the word to Rebecca to discuss more about the gut microbiome in this context of neoadjuvant immunotherapy. Thank you so much.
Thank you very much, Dr. Ines. Appreciate that. All right, so we've now got Dr. Rebecca Simpson, who is a postdoc with the Melanoma Translation Research Group based at the Charles Perkins Centre, the University of Sydney. She recently completed her PhD focusing on the role of the gut microbiome during immunotherapy for melanoma. Her research continues to focus on how diet and microbes in your gut interact with the immune system to influence the efficiency and safety of the treatment. Thank you, Rebecca. I'll now hand it over to you. And I'd also like to remind everyone, we do have the Q&A box. So if you've got any questions for Associate Professor Nesh, Rebecca or David, who's coming up next, please pop them in there and we'll look to answer those at the end. Thank you, Rebecca.
Thank you for the introduction. Let me just share my screen. So I'm now going to shift focus to my area of research, which is looking at the role of the gut microbiome during immunotherapy. First, I thought I'd focus on what the microbiome actually is and why we're interested in studying it. So the microbiome consists of the community of microbes that are present in our gut. In fact, we have about 40 trillion microbes which live in our intestines, and this compromises of several hundred different types or species. And it's now generally appreciated that the gut microbiome has a really important role in overall health. And this is because it's involved in many really key functions, from digestion and providing the body nutrients to regulating metabolism and the development of our immune system. But one of the most important roles of the gut microbiome is maintaining your gut barrier. And this is because it's really critical to preventing infection and inflammation, both locally in the gut and systemically. So the composition of your gut microbiome, which broadly encompasses this idea of who is there and how much of each of these different microbes or species are present, is shaped by many factors, from colonization at birth to environmental and host factors such as lifetime exposures and antibiotic use. But one of the biggest influences of your gut microbiome composition and subsequently the state of your gut barrier is diet. And this is because diet really influences what food or nutrients are available to the microbes and what they then utilize. And this then influences what microbes are able to thrive and are therefore there in high abundance. So focusing on immunotherapy now, we know that these immunotherapies are very successful. However, still not all patients respond. And in addition, severe immune-related adverse events or inflammatory side effects of these immune-mediated treatments are still key issues. Key research questions which are therefore important are how to improve responses, reduce toxicities, and predict clinical outcomes for patients. And this is where the gut microbiome comes in. So while there's now abundant evidence suggesting that the gut microbiome influences immune responses both locally in the gut and systemically, therefore likely that the gut microbiome can influence both responses during treatment as well as the development of these toxicities, establishing the microbiome not only as a potential biomarker to predict clinical outcomes, but also as a promising strategy to improve the efficacy and safety of treatment. And why the gut microbiome is particularly attractive is, unlike other factors which we know influence response to treatment, the gut microbiome is much more readily amenable to modification, for example, via diet, fecal transplants, or pro-antibiotic treatments. So my research therefore focuses on the role of diet in the gut microbiome in shaping immune responses during immunotherapy, and specifically how the gut microbiome influences response and the development of these toxicities during treatment. So our work on the baseline gut microbiome was published in Nature Medicine at the end of 2022. And this work really focused on the baseline or pre-treatment microbiome in melanoma patients from Australia, the Netherlands, and the US, with a particular focus on patients receiving neoadjuvant immunotherapy, which Ines has explained, where patients receive immunotherapy prior to the surgical resection of their tumor. And what we found was that pre-treatment microbiome is really important for your subsequent response to treatment. If we think of the gut microbiome as an ecosystem or a community of microbes, what we found was that particular types of microbiomes were associated with higher rates of response. Specifically, we found that Ruminocaucaceae-dominated microbiomes were associated with higher rates of response compared to patients with Bacteroideaceae-dominated gut microbiomes. So let's visualize this a little further to understand some of the key features that were different about these different types of microbiomes and why they might be associated with different rates of response. So first, what we found was that Ruminocaucaceae-dominated microbiomes were much more diverse. So what I mean by this was that there were a lot more different types of microbes present. And diversity within the gut is typically a measure of good gut health. And this is because you have lots of different types of microbes present that perform these different functions. And these can work much more cooperatively together to perform their different functions. We can kind of think of diversity and these different types of microbiomes like comparing a rainforest compared to a desert. So another key feature of these Ruminocaucaceae-dominated microbiomes were that they had a higher abundance of key fiber-degrading microbes. So this is what I've represented here by all these microbes here in blue. You can see that they're present in much higher abundance in these types of microbiomes compared to our microbial community over here. And why these are so important is that these microbes utilize fiber and produce these important metabolites called short-chain fatty acids. And these are really, really critical for regulating your gut barrier and particularly from preventing your gut barrier from becoming leaky, which drives inflammation in your gut. And thirdly, we found that these different types of microbiomes, which we found were associated with different rates of response, were also linked with different diets. So we also profiled the dietary patterns of these patients, and we found that these more diverse microbiomes were associated with higher fiber consumption, as well as higher omega-3. And these are, importantly, are key dietary nutrients which have previously been linked to good gut health across other disease contexts. So what this really suggests is the potential to potentially use diet to modify the gut microbiome, feed these good bacteria, and potentially improve response to treatment. However, this is still obviously an area of ongoing research, but still super exciting. So some key take-home messages are that the role of the gut microbiome during immunotherapy is highly complex. But there is growing evidence supporting that the baseline gut microbiome has a really important role for your subsequent outcomes. Our data in particular suggests that higher rates of response and less side effects are associated with more diverse microbiomes, associated with an increase in these fiber degraders and higher fiber and omega-3 consumption. What I guess is also important to remember is that the gut microbiome is only one of many factors which influence response to treatment. However, nevertheless, how to modulate the gut microbiome and the best strategy to do this is a really exciting and promising area to potentially modify outcomes and is an area of ongoing research. So with that, I'd quickly like to thank everyone involved in this project, and I'm happy to answer questions later.
Thank you very much, Dr. Rebecca Simpson. That was very interesting and lots to think about. I'm sure there's a lot of recipe books and people thinking about who to talk to and how to increase their gut health and their response to treatment. So thank you very much for that. Next up, we've got our patient, our MPA community member, and it is David Thiele. So David was a school principal prior to his encounter with melanoma. David is presently a tertiary supervisor of teacher undergraduates at ACU in Canberra. And along with holding key leadership positions in a number of schools, David has also worked as a senior officer in the Catholic education area at Canberra and Goulburn. David was diagnosed with stage 4 melanoma in 2016 following the discovery of a large mass between his heart and lungs and subsequent metastases in the lungs and adrenals. No primary melanoma of the skin was found. Although not without its side effects, David's main form of treatment had been immunotherapy and presently has no evidence of disease. In between the busy life of work and keeping active on the golf course, David is a dedicated MPA volunteer, facilitating the monthly support group in Canberra, as well as being a valued member of the MPA Consumer Advisory Group. Thank you and welcome, David, to share your insight and story as a patient.
Thanks, Emma. Yeah, just after listening to the last one, I'm not quite sure where I fit in here. But I guess I can just tell the story of my gut journey on immunotherapy, which I guess is essentially in two parts. The first part was I commenced nivolumab back in 2016, which for about 6 months. And after that, the melanoma had progressed both in my lungs and the large masses elsewhere. So it was decided that I would, go on to the ipilimumab and nivolumab combination treatment. So I was on fortnightly nivolumab for 6 months, and then the protocol for this new combination treatment was every 3 weeks for 12 weeks, so a series of 4 infusions of the combination, which I'm sure many of you are familiar with. Tolerated that okay for the first sort of 6 or so weeks. Following about the third treatment, I guess side effects started to come on, and one of those was colitis, which I wasn't even familiar with the word or the term colitis at the time. I just knew I was beginning to go to the toilet a lot more. I mentioned it a few times. We just keep an eye on things. I've noticed these days, following the MPA Facebook group, that quite often when someone commences the ipi-nivo combo and they might come down with colitis, they stop. They tend to get onto the steroids, and when that's all cleared up, they continue on the process. With mine, we just went through. Again, this is back in early 2017 now. After about the third, I think, or the fourth treatment, by this stage I was toileting probably every 10 to 15 minutes. A good break was about 30 minutes. So as you can imagine, there was not much time for sleep in between any of that. I was still trying to work at the time, and that made things a little difficult as well. Excuse me. And then ended up, excuse me, I'll just have a quick drink. Okay, so by this stage, I was recording my toileting and what was taking place, and eventually they decided to put me in hospital. I commenced some high dose steroid treatment. I was having it intravenously as well as tablet form. But at the same time that was coming on, a whole range of other autoimmune diseases were beginning to appear. Hepatitis, diabetes, clots developing. So a whole range of other things were going on as well. So I had a combination of medications trying to treat a lot of these things. Eventually sort of headed down the path of renal failure, but with the amount of steroids that I was on, that induced osteoporosis. So then my bones began to get brittle, and particularly so breaking ribs, etc. And then, but my spine then also had quite a number of crush fractures of the spine, brought on by the osteoporosis. So then I started to get obviously pain with that. So then began courses of opiate medication to manage the pain. So in all, I had about 3 months in hospital at that time. The colitis disappeared because that changed to opiate constipation. And cut a long story short, we eventually released from hospital and went home under palliative care. So that was the first part, I guess, was the Ipi/Nivo bringing on really, really severe colitis. When it first came on, my oncologist was overseas. They tried to deal with him sort of over the phone. And again, we just pushed through treatment. I didn't miss a treatment of that the entire time. And even the time I was in hospital, that 3-month period, I didn't miss a treatment. And we just pushed through. So my gut was pretty bad. But then, as I said, finally had, I wasn't even going to be released from hospital at the time because I hadn't tolerated it for so long. And they were giving me injections and a whole range of things to try and get some bowel movement so that I could then actually go home. We eventually got that far and I got home. But then issues came up with, because of the bone scenario, it was recommended I had 6 servings of dairy a day, along with other, I was having a cluster infusions and a whole range of other things to strengthen the bones. And before I commenced sort of doing that, and I lost 14 kilograms in hospital in weight. And so I was trying to eat well and to eat a lot to try and gain some weight and to gain some strength. But all of a sudden I became violently ill from both ends. So violent vomiting, violent diarrhea. Had the nurses from Clare Holland House, which is our hospice here in Canberra. They would come and administer appropriate medication that I had here. And this went on for a while, and some days it would happen and some days it wouldn't. And couldn't quite figure out what that was because while that was going on, the Ipi/Nivo combination was actually working. Tumours were shrinking. Some in my lungs were even disappearing. So that side of things was working. But again, I was having these bouts of violent illness. And in the end, we started to think that might have been something that I was eating. And I started to trial things. And so I'd be quite fine in the mornings. And I was making protein shakes, or having family members make protein shakes, which included milk and yogurt and eggs and that sort of stuff to try and build up my strength and build up my bone strength and that sort of stuff. But I would have that, and a few hours later, I wasn't putting these two together. But a few hours later, I'd be again violently ill. And then we decided that we'd stop that, and we weren't sure what it was, and those things stopped. But I'd had other foods, such as we had health food bars and those sorts of things. And it wasn't until I cut out the health food bars, cut out the yogurt, cut out things that had, the bars that had cashew nuts in it, that all of a sudden it stopped. And in conversation with the oncologist and doctors, they seemed to think that the severe colitis, and the doctors could confirm or deny this, I'm not sure, I still don't know really, said that the lining of my intestines and gut had all been perforated and eaten away by the colitis. And so the yogurt and cashews and these various things, which were just for me, were what making me violently ill. And as soon as we stopped those sorts of things, my gut health came back. to the point now where I can have all of those things again. But at that time, it was just horrific. So I'm not sure how that fits in with tonight's, but that's my sort of gut health story. Emma, if that helps, I'm not really sure.
Yeah, absolutely, David. And do you want to share, so the success of your treatment? So you went through a bad trot, I guess you could say, in terms of side effects, but where are we at now, David?
Look, I'm
7
great.
years now.
Yeah, no, as I said, it was a long time ago, and I think the protocols are different now, fortunately, and they've all learnt, and there's been an example. And the only issue now, of course, is still dealing with chronic pain through a back. But yes, I'm just a bloke with a broken back now. I have no disease, nothing whatsoever. So all's good. Yeah, gut's great. General health is great.
Yep.
Yeah.
So it was really that treatment phase. And if we can get Associate Professor Ines and Dr. Rebecca as well, it'd be interesting to hear their thoughts, and if they've seen patients and through their studies as well, that the gut microbiome changes then from, you know, when the person's going through immunotherapy, and then once that subsides, how do we see that often, that there is kind of going back to normal or a reset phase as well?
Well, I'm going to leave the gut microbiome part for Rebecca. But what I can comment as a clinician, what David mentioned is quite, well, I'm so sorry to hear what you went through. Unfortunately, that's one of the possible side effects with immunotherapy, even though immunotherapy is great, and we are getting better and better at really helping patients not suffering from those side effects as you just described. But just one thing that you mentioned that was very interesting is that after the bad phase of colitis, where your the mucosa, right, so the lining of your gut is very inflamed, that things like yogurt and nuts, they were not doing good. One of the reasons is because with immunotherapy, so the way it works, so it's probably easier to understand, is, as I mentioned in my presentation, we don't, what we want is to activate the immune system to fight cancer, right? But unfortunately, by doing that, in some cases, but we're not good at identifying which patients, but in some cases, unfortunately, the immune cells started to affect normal organs. So, for example, like going to the gut and create some inflammation in the gut. That's why then it translates into colitis, okay? The itis at the end means inflammation. Okay, so that's how it happens with immunotherapy. So we stimulate the immune cells to fight the cancer. In some cases, for some reason which we haven't really identified yet, sometimes the immune system also affects, for example, the gut. Now, because it creates some inflammation, what happens is affects the mucosa and the lining of the gut, and we lose some enzymes that are important to digest all these. So what you were saying, yogurt, and so that's why it makes everything worse. But once you give some rest to the gut, then everything gets better. That's just to add that information, but your description was very informative, okay? Not only for other patients, but also for us, for me, for example, as a clinician. But I'm going to leave the part of the gut microbiome, but I know that Rebecca has more information on that. So, yeah.
Yeah, so in terms of how the gut microbiome changes during treatment, this is kind of an area of our ongoing research. So in addition to the baseline samples, we also have additional longitudinal samples, and we're now working on understanding how the microbiome changes. Do we get bigger changes in the context of patients who get these severe toxicities such as colitis? The truth is we don't really know yet. My gut feel is that likely are changes in the gut microbiome, particularly in the context of colitis, and that there's likely a recovery period back to what your normal baseline is after these immunotherapies. But yeah, this is definitely an area that we're still working to really understand the dynamics of the microbiome and what's going on.
Yeah, absolutely. And we had a question that came through that asked, how important is the gut microbiome for a person who has responded well to neoadjuvant immunotherapy and to continue that gut health after treatment? And I think we probably answered that, in that, you know, we don't know exactly the intricate details, but it's probably important that we focus on the good gut health throughout that process. Would you say that then, Rebecca, whether you were positively going through the immunotherapy or not?
Yeah, I definitely think that, well, continuing to promote good gut health is only going to be good for you, not only in terms of ongoing response to immunotherapy and but also just in general for your overall health. So there's no harm in continuing to eat well and support your gut health.
Yeah. And in terms of that research that you have been doing, someone was asking if there will be eventually similar research done on targeted therapy. Has that been looked at before, or has it been discussed at all in the industry?
I think there's definitely research in this space across different types of treatment. I know that we've also collected samples from some other trials which also involve combinations of immunotherapy and targeted therapy. So it is something that we'll eventually look into further and compare whether it's the differences with immunotherapy and targeted therapy and whatnot.
Yeah, okay, great. And Ines, you talked about the neoadjuvant being the best thing someone can do for stage 3 resectable. We had a question around whether that's standard treatment now in general. Is that just for that stage 3 resectable, or are we seeing that more commonly across the other stages as well?
No, so very good question. So let me just probably take a step back so I clarify. It's definitely the standard of care for resectable stage 3 and is available in Australia. So standard of care based on data, right? So that's presented in big meetings, medical meetings, and we are very lucky to be in Australia where this is available. But just to clarify about other stages. So, and apologies, some of the people already know what I'm going to talk about. But in general, we have 4 stages. Okay, stage 1 and 2, and it's similar across cancers. But let's say in melanoma, stage 1 and 2 is when we have local disease, so a primary melanoma, right? In some cases, we don't find a primary melanoma, but in the majority, we'll find like a mole that is a melanoma. That's stage 1 or 2, depending how big, okay, with nothing else. Stage 3 is when the regional, so the lymph node in the same region is involved, okay? And stage 4 is when it has spread. So what I explained about neoadjuvant, it's only applicable in stage 3. Resectable, okay? There are some cases where surgery is not possible. So this, I'm talking about stage 3, so meaning regional lymph nodes that the surgeon can easily resect. And yes, is a standard of care.
Right, no worries. And we've got someone that also asked about they're finding that surgeons are reluctant to operate on stage 4 metastatic melanoma patients. Is that something that's common?
Yeah, so based on what I just explained, so the 4 stages, stage 4 is when the cancer has spread to other organs, for example, lung, bone. So it's not necessarily that the surgeon is reluctant, is that does not make a big impact. Okay, it's not the standard. Okay, so we treat patients with stage 4 with systemic therapy. Okay, but those all patients are discussed in multidisciplinary team meetings, and it's the best decision for the patient based on what we think. Yeah, when it's discussed.
Yep. We've got a lot of people talking about probiotics and over-the-counter supplements. Can either of you provide any feedback on that, or any thoughts around utilising that through treatment or even afterwards as well?
Okay, so in terms of probiotics, there's actually data that's come across from other groups which have shown that over-the-counter probiotics actually might be detrimental to responses. So I think the general idea at the moment is to not use over-the-counter probiotics. The main reason is we don't really know what these over-the-counter probiotics contain and what they're actually going to do when you then add these to your gut microbiome. I think eventually when we understand more about the microbiome and which microbes we actually want to be introducing, we'll develop more, I guess, precision or specific probiotics to specifically support immunotherapy. But right now, I think the general recommendation is actually avoid over-the-counter probiotics because we really just don't know.
Okay. So it sounds like it's coming more from a diet-specific process as well. So working with dietitians, I would suggest, would that be what you recommend when you see patients coming through? I've got a lot of people asking about, types of foods they should be taking and eating.
I can give you what I normally tell my patients when they ask that question. Again, I treat lung cancer and they ask a lot about this question, and I use a lot of immunotherapy. So, and again, Rebecca, I would love to hear what you want to say, but what we have evidence so far, what all the research is showing so far is that it's always better to have variety in terms of diet, fresh food more than processed food. Probably fiber has been shown to be good, but we don't have, and that's what I normally tell my patients, because they come and say, what should I start eating and what should I stop eating? And the truth is we don't have any strong evidence one way or the other, right? We don't have any strong evidence we should stop this or we should start from now on, eat mainly this. So I always say that balanced diet, fresh food more than processed food, yes, enriched in fiber, but balanced, because the truth is the body is already dealing with a cancer and then with a treatment. So big changes without evidence, I'm not too sure it's a good thing necessarily, but that's my opinion as a researcher and a clinician. Yeah.
Yeah, I definitely agree, I guess. At the moment, we don't have clear evidence of what specific nutrients are good or bad. So, and it's definitely a field or area of research that is increasing, but we currently haven't had trials or routinely tested specific nutrients. So we can't really give any recommendations other than what's generally known about diets that promote good gut health and as Ines said, diverse, balanced diets.
Yeah. And for you, David, it sounds like there was a bit of trial and error and that you went through a process of elimination and it really was an individualized thing for you. Did you seek help for by any medical professionals in that respect, or was it just your own little journey that you went on and did some investigation?
Just all guesswork, really. I was bedridden for sort of 8 months anyway with my back, so I couldn't go anywhere or do anything. I'd get out once a fortnight to go back in for immunotherapy and or to doctor's appointments. But apart from that, it was just I had a walker, and I was trying to walk a few meters each day, and sometimes at the end of that, I was thinking that was the issue. I was if I walked 100 meters, I thought maybe that was too much, and that's why I became ill again. And then I started to get a bit of an inkling of it. So I actually tried, rather than just have a nut bar with, say, cashews in it, I'd eat one cashew and just to see what happened. And I did. I became quite ill and upset, but I didn't. And it wasn't until I vomited that I then felt better again. So I then I was game enough to have a go at just little bits just to see. So rather than having a big amount and being violently ill, it just had enough just to say, yes, that's definitely, I can't have that anymore. And so I guess I just trial and error, experimented with it. And unfortunately, no offense, associate professor, you talk to an oncologist and they say, well, talk to your GP at that point. oncologist was mainly concerned with the cancer, and anything else seemed to be pushed over. And at the time, I was under a cardiologist, an oncologist, endocrinologist. So just trying to find the right person to have that conversation with. But people, most of the time, it was, oh, not quite sure. Yes, it's possibly the immunotherapy. So I just experimented with what I could or couldn't eat anymore, and it wasn't a lot of things. I think one of them was it come down to the gum or the emulsifiers that was holding those bars together. And as I said, cashews was one in particular, and I don't know why I always liked cashews, and it was definitely the yogurt. And we just cut those out, and over time, and as I said, the colitis had healed. I was, at that stage, I'm now taking things to go to the toilet because of the opiate constipation. So the only time it was like that anymore was when I had something that I couldn't tolerate. So we worked out what those were just by trial and error.
Thanks, David. And we've got someone on the line that's interested in seeing where you're at now with your treatment. They want to know if you're continuing immunotherapy, but I understand that you've finished that now and you haven't had any type of treatment like that for some time. Yeah,
no, I've had the 6 months of the Nevo, then the 12 weeks of the Ipi-Nevo, and then about 4.5 years of Nevo, and then in the end it was sort of my call to stop. My oncologist would say, things are going well. You have a scan and things are going well. Do you want to continue treatment? And I go, well, should I continue treatment? He said, oh, well, I don't know. So it's one of those things. I think the protocols are all different now. They've moved on a little bit, but in the end, I said, well, let's do the next PET scan, and if it's clear, we'll stop. And that's what we did. And did 3 monthly scans for 18 months, I think, and I'm now on 6 monthly scans, just CT and CTs and MRIs. But apart from that, no treatment. I still have a cluster infusion for my bones, which I had only last week, actually. So, but that's the only thing. Yeah.
Okay, fantastic. Well, we're coming to the end now. We're just about to hit 8 o'clock. We have answered a majority of, the themes that are coming through. But remember, if you have any specific questions that are personalised, please reach out to our teams at MIA and MPA. Talk to your GP or your oncologist. We're all here to help. I'd like to thank our wonderful speakers to give up their time this evening and sharing your insights with us. So very big thank you to all of you for being a part of our webinar this evening. Just a friendly reminder to complete the survey that will pop up when you close out the webinar this evening. And we hope to see you all at next Tuesday's webinar. And please make sure that you do register if you haven't. But for now, good evening, and thank you all for joining in, and thank you for our speakers. Take care and goodbye.